Dear Chair, dear audience, good afternoon, everybody. My name is Bertalan Tordai, and I would like to present the first year progress of our research on effect of migration on health care. I'm a physician with two specialties, military medicine and occupational health medicine. Me and my team have a vision, which is to assist migrants and immigrants in successfully integrating the host societies by identifying effective interventions for improving the health outcomes of migrants and immigrants. At the moment, we have two ongoing projects. The first will aim this topic on a global level with the help of a systematic review and meta-analysis, and the second one will aim the EU with the help of a Eurostat analysis. The first project of ours is on investigating the cardiovascular risk of immigrants in comparison with the host population. Immigration is a specific phenomenon. In 2020, more than 200 million immigrants arrived into the developed countries. Nowadays, is much more focused on refugees and asylum seekers, the first generation immigrants who have already settled down into the host societies, pose a unique challenge to the healthcare systems. It is already known fact that the prevalence of cardiovascular risk is declining in the developed countries. From its peak from 1995 till 2020, it decreased by 60% across the EU, but it still accounts a huge amount of money of the total healthcare expenditure of the Union. Meanwhile, it is not known that this influx of immigrants impacts this declining trend. As a selective preventive strategy, we aim to identify the main modifiable atherosclerotic cardiovascular risk factors, which are high blood pressure, obesity, diabetes, smoking, and high cholesterol, among the first generation already settled down immigrants, and compare it with the host population risks. To meet our goal, we have formed the following clinical question. What are the levels of the main modifiable atherosclerotic cardiovascular risk factors among immigrants compared to the host population? And to answer this question, we will use the PECO framework, where we will compare first generation immigrant adults and hosts, and we will look for the previously mentioned cardiovascular risk factors. We hypothesize that these factors will differ between immigrants and the host population. And if this is true, we can directly transfer the results to support the development of effective and efficient cardiovascular preventive strategies. We have done our search with two domains in 3 different databases, and we have got almost 20,000 hits. What we managed to shrink down till 638 eligible full texts. Our outcome measures will be proportions, odds ratio, and mean difference. Most of our analyses are ongoing, but we have preliminary results on diabetes. This is the first plot, the first forest plot we have complied. We grouped the studies according to the United Nations regional classification, and we have chosen the European region as host to be examined first. From 33 studies which contained data on European hosts, we pooled result for diabetic persons, because this forest plot shows the proportion of the individuals living with diabetes. The pool result of diabetes was 5%, which result is also indicated by the gray line running across the figure. And after that, we have managed to form 5 groups. First is Asia, from 6 studies with a pool result of 13% of diabetes prevalence. This is statistically significant and clinically relevant result. Middle East and North Africa from 28 articles with a 9% pool result, which is also statistically significant and clinically relevant result. South America, we could only include 3 studies with a pool result of 4%, which is not clinically significant, but may be clinically relevant also. South Asia with 8 studies with a pooled result of 15%, which is significant statistically and relevant clinically. and the sub-Saharan region of Africa from 14 studies with a pool result of 8%, which is likewise significant, statistically significant and clinically relevant results. So, as a summary, we grouped the studies according to the United Nations regional classification. We chose our first host region, Europe, and we found that 4 out of 5 regions, the first generation immigrants have higher prevalence of diabetes than the host Europe population, except South America, which result is limited due to the small amount of studies we could include. We can see that we have 2 different kind of heterogeneity values. The first, that's why, because most of the studies reported data not just on the host population, but also on at least one immigrant population. So we applied a multi-level statistical model, which resulted these 2 different heterogeneities values. The first is between study heterogeneity, which stands for the conventional value, conventional measure of heterogeneity, which shows the heterogeneity, the variability between different studies data, and within study heterogeneity, which shows the variability of one single study's different data pools, so host and immigrants data. These are both moderate, they show both moderate heterogeneity, around 50%, but we think the total heterogeneity, which is 100%, is much more informative, and it's the actual heterogeneity of our study, and obviously due to the massive heterogeneity, both host and the immigrant population. So we are at the figure and tables phase, and we are doing the risk of bias parallel. I would like to jump to my second study, which is on investigating the prevalence of the cardiovascular risk factors among immigrants in the European Union. As we have seen, immigration is a significant phenomenon which affected Europe in the past 10 years particularly, with the fact that in the last 3 decades, more than 10 million avoidable cardiovascular deaths occurred across Europe. We would like to analyze the cardiovascular risk factors among immigrants with a comparison with the host country residents and EU averages, and we would like to adjust these results for socioeconomic factors like age, education, income, and gender. These aspects are closely connected with the trend of prevalence of cardiovascular risk factors, which is declining in the developed countries, in the host countries, while elevating in the developing ones where most of the immigrants come from. For this study, we would like to use the Eurostat database. Eurostat is the statistical office of the European Union, where a bunch of statistical tables are available, and they are regularly updated by service statistical institutes and administrative sources. So this process makes the data fresh. Eurostat provides the data as macro data and micro data. Micro data shows individual level data. We would like to use these data, so this way we can make our study more detailed and deep. The clinical question for this project sounds: how do cardiovascular risk factors and major cardiovascular events among EU immigrants differ from those in the host population, considering the influence of education, income, age, and gender? To answer this question, we will use the PEO framework, where the population will be the people aged over 15 in the EU countries. The immigration will be the exposure, which will be represented by the date of country of birth in the Eurostat database, and we will look for the same cardiovascular risk factors in the previous study. We hypothesized that the prevalence of the risk factors and major cardiovascular events is higher among immigrants than in the host population, with social factors playing a significant significant role. If that's true, we can directly support specific preventive measures with the simplest and most financially advantageous way possible. So as a summary, we have two ongoing projects, a global scale project which uses the method of systematic review and meta-analysis, a narrow one aiming the EU with the help of Eurostat Analysis. The first is planned to be submitted in the end of autumn this year, the other one in the summer next year. And I would like to close my words with lines of Tennyson from the poem of Ulysses, referring back for the past 4 months of data extractions, horror. One equal temper of heroic hearts made weak by time and fate, but strong in will to strive, to seek, to find, and not to yield. Thank you very much.
Thank you for the very important topic presentation and a nice presentation. Does anyone have questions from the audience?
Thank you for your very nice presentation. It was a really interesting and important topic to talk about. Do you have any theories, or have you have you stumbled upon some sort of theories that could explain or could say something about why this prevalence distribution can be seen in the immigrating population?
First of all, I have to emphasize that these are preliminary data, but I don't think that these will change massively. You know, these results come from modifiable and non-modifiable causes, risk factors. So I think it's basically non-modifiable, so that means genetics. And let's say, I think also a non-modifiable factor is the public health and the general health sector of the origin, region, or country. So of course, it's modifiable, not by us. And after that, the different lifestyle of the immigrants. So these three.
Thank you. Also, immigrants may have a much higher level of stress.
Yeah.
Is there any, are there any studies, or is there any additional information on that?
Yes, but mostly on refugees and asylum seekers, and we excluded them from the data collection because we would like to focus on already settled and who are here and will remain here. Yes, a part of the asylum seekers and refugees will be first-generation immigrants, but until they are not accepted by the host, they are excluded for our article.
So basically, these are consolidated or less, like I would say, ordinary.
I think they would have much higher than the host, but much lower than when they were in the asylum seeker state or refugee state.
I see.
Congratulations to the huge work. It looks like a lot of papers and enormous data set. My question would be that how specific are these results for the immigrants? Did you compare the country of origin and the prevalence of the disease there with the prevalence of the disease among the immigrants?
So you mean first-generation immigrants and the origin country?
Yeah, so for example, people from South America, Europe, and people living in South America.
This study, so we did not include this in the SOP of our study, but yes, we got some data, and even we think about that we should pull data from public databases from the origin countries and do that, but it will be a different one, not this one, I think so.
Absolutely. Any other question? Yes, please.
An OT guy.
So we can see from your study that immigrants have a higher risk of having diabetes and certain cardiovascular diseases. In the end, what are you hoping? How would you implement this information into guidelines or strategies? I mean, wouldn't the current tools and healthcare screening strategies are not enough, which are applied to the general population, because you're investigating immigrants who are already settled, so they should be reached by the already implemented, guidelines and strategies. So what are you hoping at the end from this?
I think it's mostly the first step is mostly is on decision-making level. So not a clinician level or operational level. Yeah. So this is the first one, to help the decision makers, the healthcare decision makers or larger higher decision makers to think about this problem, and when they make regulations and after that guidelines, etc., then take consideration this information.
But do you think, for example, the guidelines should say, that GPs, family doctors should specifically look for, immigrants and tell, oh, you're an immigrant, so let's check your blood sugar and blood pressure, or you have to come back?
That's an interesting question. Here in Hungary, we don't have so much affected, or let's say affected, or specific first generation immigrants, what should stand as a problem, or a real problem, but there are Western countries who have first. And yes, I think we should, it's on camera, but okay. So I think it's a politically correct way to say that we are the same, and everybody have to be handled the same way. So if you say that you, in your specialty, you apply patient-specific treatment, something, then in the primary care we should apply patient-specific care, which includes the the origin of the patient.